Welcome to my progress report presentation on tissue acquisition in solid pancreatic masses. My name is, as mentioned, Marie Engh, and my vision is that improved diagnostics of pancreatic cancer can lead to better outcomes for the patients. In this, my mission is to contribute to clearer guidelines for more efficient diagnostics of pancreatic cancer. I have two topics in this topic about the techniques and the equipment that can be used during tissue acquisition. The first is a network meta-analysis that compares the diagnostic adequacy of needle tips in this diagnostic method. And as a quick background, endoscopic ultrasound-guided tissue acquisition is a common diagnostic method in solid pancreatic masses. However, 10% of samples are inadequate for analysis. This leads to a need for resampling, which carries a risk of adverse effects, a need for sedation, and costs of around $2,000 per patient. Now, here you can see the 5 needle types that are available for this sampling method. The first is an aspiration needle, which is, the design is called Menghini. Then you have the Westcott needles, forward and reverse bevel. They're kind of like the Menghini, except they have a tissue core trap on the side. And then there are 2 crown cut needles, the Francine and the fork tip needle. These are the newest, and the idea is that the design of this crown cut will be more efficient at cutting a tissue sample out of the mass. In the guidelines for this, it only says that 19-gauge FNA needles or FNB needles and 22-gauge FNB needles should be chosen for a core tissue specimen. However, the level of evidence is low, and the recommendation is weak. So our aim is to compare the diagnostic yield and adequacy of all the needles used for tissue acquisition. Our question was, if in a population of patients undergoing endoscopic ultrasound-guided tissue acquisition for a solid pancreatic mass, the choice of any FNA or FNB needle will lead to a higher diagnostic adequacy, specimen yield, or will change the number of passes, the adverse events, or technical failures. We performed our search in October 2021, however, we've since updated it on May 5th. We found 3,600 records, of which 78 full text remains. These are all randomized controlled trials. Here you see our network for histological adequacy. Each blue circle is a node. These are the different needles of different sizes. And the lines represent direct comparisons. So if you see between the 22 gauge and the reverse bevel and Menghini is the strongest comparison, most studies compared these two. And we were able to establish this ranking for this outcome, where fork tip needles and Francine needles performed the best, and Menghini needles the worst. If we disregarded the size, this is another network, we found this order where fork tip and Francine needles were by far the best and Menghini the worst. For our outcome of cytological adequacy, we again have a network, it works the same way. And we found this ranking where fork tip needles were the best and Menghini needles the worst. When we disregarded the size, we again found fork tip and Francine needles to be the best, followed by reverse bevel and then Menghini needles. For technical failures, we actually found that the Francine needles were the best, however the reverse bevel were the worst. And in the ranking without size taken into account, you can see this. For adverse effects, we found reverse bevels to be the best and Francine needles to be the worst. However, the rate of events was very low for this outcome. Not regarding the size, we still found reverse bevel needles to be the best and Francine the worst. To sum this up, this is a network meta-analysis including more than 50 studies and thousands of patients. It compares all the available needles for endoscopic ultrasound-guided tissue acquisition in several sizes. However, there's a high uncertainty which leads to wide credible intervals, and there's no statistically significant differences due to this uncertainty. However, we would like to conclude that fork tip and Francine needles are best for achieving adequate samples, and Westcott needles carry the least risks of adverse events, but these are rare either way. So for practice, we want to recommend that you choose fork tip or Francine needles if adverse effects and technical failures are not of concern. And 22 gauge or 25 gauge fork tip needles are best for a tissue core. For research, we think that further RCTs should be performed comparing different or several needles. And adverse effects should always be clearly defined in the future papers. The adequacy for cytology and for tissue core should be reported separately. The manuscript status of this is we're still writing the article without final results because we want to create one more network which takes only size into account and not design. And our target journal is gastroenterology. My second project is about contrast-enhanced endoscopic ultrasound and it likely not increasing diagnostic adequacy during tissue acquisition from solid pancreatic masses. The background is similar, however, now we're looking at endoscopic ultrasound, and this can be either conventional or contrast-enhanced. If you use contrast, you might increase the visibility. However, you will decrease the time window during which the sampling can be performed. So this could go either way, and our aim is to investigate whether contrast-enhanced ultrasound may increase sampling adequacy of solid pancreatic masses. We have a population of patients undergoing tissue acquisition for a solid pancreatic mass, and we're comparing the intervention of contrast-enhanced endoscopic ultrasound to conventional ultrasound, and the outcomes are the same: diagnostic adequacy, specimen yield, number of passes, and adverse events. We performed the search in the end of April 2022. We found 343 records and ended up with 11 eligible full texts. For our outcome of diagnostic adequacy, we found a risk ratio of 1.16. This is not statistically significant, and the level of evidence is low. However, if you look at Sugimoto, the trial here, you will see that they had an astonishingly low rate of adequate samples in the conventional group. And when we went to look at this paper, we found that actually for the first pass, and we're only considering the first pass here, they were being performed by not experienced endosonographers, and only the following passes were performed by experts. So we think that the reason that this is so different is because these are endosonographers with less experience, and maybe this intervention can actually help those who don't know how to properly perform a tissue acquisition. When we excluded this, we actually found a risk ratio of 0.988, and here the confidence interval is so narrow that the imprecision is low and the grade of evidence is moderate. For the secondary outcomes, we weren't able to pool it because of a zero event rate in both arms for almost all the studies, and the level of evidence is very low. We also found 3 ongoing trials, one of which has already completed the patient enrollment, and 2 of which are supposed to complete in the next few years. So we think this meta-analysis will have to be updated once these are published. To sum this up, we included only randomized controlled trials, and we have a low risk of bias for the main outcome. However, we included few studies that had different methods and differing definitions, and there was a low number of events for the secondary outcomes, as well as low or very low level of evidence. We would like to conclude, however, that there's no difference in diagnostic adequacy, and that maybe this intervention only helps inexperienced endosonographers. For practice, the implication is that this might be worth using if only inexperienced endosonographers are available. And for research, any further RCTs should consider stratifying for the experience of the endosonographer. And current ongoing RCTs should report the experience and the lesion size. And again, this might need to be updated later on. The manuscript status is the article draft is finished with the supervisor, and hopefully we will be able to go to internal review soon. Our target journal is gastrointestinal endoscopy. To sum it up, hopefully I will submit the first paper by October 2022 and the second paper by September 2022. I would like to thank for your attention with this ancient proverb that a good paper tells a story, a published paper cites reviewer 1, survives reviewer 2, and buys reviewer 3 a beer at the next conference. Thank you.
I have one question concerning the first study. As I remember, in case of Mangini needles, they're worse in almost all of the comparisons. So would you argue against the use of Mangini needles?
It depends. So Mangini needles are still the cheapest of all of these because they're being produced by many different brands. So basically, it will come down to finances. I know there's countries that can't always afford the most expensive equipment, and they're still adequate for example, cytological adequacy. However, if you can afford it, I would recommend against Mangini needles, especially for biopsy, because they're actually aspiration needles.
So what type of needles do we use in Hungary? I'm not an expert in this area.
That's a good question. I think it depends actually on the center, but I think reverse bevels might be the most common. I know in Germany they're using the Francine one mostly.
I'd like to ask what gave you the idea to look at the experience of the people doing the examination, because that's not something I would have thought of when you started talking about needles and so on and so forth.
Well, I think that a very key part of the sampling process is targeting the lesion correctly. So the reason that the harmonic, the contrast might help is because you're able to identify the fibrotic parts of the tumor. And if you sample from the fibrotic parts, you won't be able to make a diagnosis of the lesion necessarily. So with the contrast enhanced, you will see if it's fibrotic because you will see if it's hypoenhanced or not. Whereas an experienced endosonographer might be able to tell this even from the conventional ultrasound already. So this was my reasoning, and when I looked into it, I found that the inexperienced ones had only 300 EUS as experience, whereas the experienced ones in the other paper had more than 7,000, so this was a huge difference actually.
Did all of the studies report on the experience of the that person?
Yes, they did.
Thank you.
Thank you for the question.
I am just curious, like, what is the exact cutoff for experienced and inexperienced sonographers, if you know? Thank you.
I don't know if there's a very clear definition that says, it's exactly 1,020 or something. I don't know if the experts know this maybe, but to me, just the difference between 300 and 7,000 was big enough to think that that might be playing a role exactly here. Also, the papers themselves described them either as expert or experienced, or in the other paper as the first pass was performed by endossonographers with 300 passes in experience, and then any following needed pass was performed by experts. So they already clearly agreed that these were not experts. Thank you for the question.